You turn 65. You enroll in Medicare. You feel protected. Then you go to your dentist, your eye doctor, and your audiologist, and you get 3 full invoices. Not 3 copays, 3 bills, because Medicare paid nothing. This is not a coverage gap anyone forgot to close. The Social Security Amendments of 1965 contain an explicit exclusions list. Section 1862 names what Medicare will not pay for. Dental care is on it. Eyeglasses are on it. Hearing aids are on it. Congress wrote those words in. And for 60 years, with narrow exceptions, those words have stayed. The question is not whether these things are expensive. You already know they are. The question is why the program that covers open-heart surgery does not cover a filling, and what you need to do before you need the answer. Here is the mechanism. Congress did not forget to include dental care in Medicare. Congress decided not to include it. The Social Security Amendments of 1965, Title 18, Section 1862, lists what Medicare shall not cover. The language is specific. Services in connection with the care, treatment, filling, removal, or replacement of teeth. Eye exams for prescriptions. Hearing aids and examinations for fitting them. These are named categories written into federal law that have remained in place for 6 decades. The 1965 political calculation was precise. The American Medical Association had fought Medicare for years, calling it socialized medicine. To get the bill passed, Congress built Medicare around what the AMA would accept: acute medical care, hospitalization, physician services for illness and injury. Dental, vision, and hearing were classified as routine maintenance, not acute illness. And that classification held. The result? Medicare covers a quadruple bypass, but not the tooth infection that could have prevented it. That is not a metaphor. That is the statute. And here is what most people never find out. The 3 exclusions operate through different mechanisms with different dollar consequences. The one that catches people first is the one they assume their dentist will handle. Medicare does not cover a cleaning. It does not cover a filling, a root canal, a crown, an extraction, or a set of dentures. Section 1862 covers everything related to teeth and the structures that support them. There is one exception, and it is narrow. In the 2023 and 2024 Medicare Physician Fee Schedule final rules, CMS defined a category of dental services Medicare will cover. Services inextricably linked to a covered medical procedure. If you need a tooth extracted before an organ transplant to eliminate infection risk, Medicare can pay. If you need oral care as part of treating head and neck cancer, certain services may qualify. CMS is specific about which procedures trigger coverage. The list is short. It does not include the crown you need because your tooth is cracked. According to research on Medicare beneficiary costs, dental spending averages over $800 per year out of pocket for beneficiaries who use dental services. A single crown runs $1,000 to $1,700. Full upper dentures average $1,600 to $3,000. These are not luxury procedures, and nearly half of Medicare beneficiaries skip dental care in a given year because they cannot afford it. Here is what most people never find out until they need it. Your Medigap policy does not cover dental either. That is a separate problem with its own mechanism. But before Medigap, there is a second exclusion that operates on the same logic, and it is sitting directly in front of you, literally. Medicare does not cover a routine eye exam. It does not cover eyeglasses or contact lenses. If your vision has changed and you need a new prescription, you pay for the exam and the lenses. Section 1862 excludes eyeglasses, except for one pair furnished after cataract surgery with an intraocular lens insertion. Read that parenthetical carefully. Here is the line. Medicare Part B covers treatment of diagnosed eye diseases, cataract surgery, anti-VEGF injections for wet macular degeneration, which run $1,000 to $2,000 per injection, and glaucoma screening once a year for high-risk patients, those with diabetes, a family history of glaucoma, or African Americans over 50. These are covered because they treat a medical condition. The routine annual exam that catches those conditions early? Not covered. The Commonwealth Fund's 2018 analysis of Medicare vision coverage documents the mechanism precisely. The program will pay to treat advanced disease. It will not pay for the checkup that catches it first. That is the logic Medicare applies across all three exclusions. A standard eye exam runs $100 to $250. Prescription eyeglasses average $300 to $600 per pair. Over 20 years of retirement, the math is real. But the third exclusion costs the most per item and affects the most people over 70. And most of them find out about it only when they are already in the store. More than 2/3 of Americans over 70 have significant hearing loss. Medicare covers hearing aids for none of them. Medicare Part B will cover a diagnostic hearing exam if your physician orders it to evaluate a specific medical complaint, to rule out a tumor, to assess nerve damage. If your doctor orders it to investigate a symptom, Medicare can pay. What Medicare does not cover: hearing aids, fittings for hearing aids, or exams for the purpose of prescribing them. Section 1862A(7) is explicit. The average pair of hearing aids in the United States costs $4,700. High-end digital models run $6,000 to $7,000. In 2022, the FDA implemented regulations under the Over-the-Counter Hearing Aid Act, allowing adults with mild to moderate loss to purchase aids without a prescription, starting around $200. That expanded access for the mild to moderate population. For moderate to severe loss, OTC devices are not adequate, and Medicare still pays for none of it at any price point. Think about what that means for your retirement budget. You will likely need hearing aids. You will replace them every 3 to 5 years. You will pay entirely out of pocket with money you already paid taxes on, using a Medicare card that does not cover the purchase. That is not a metaphor. That is the actual statute. And if you think that is the largest financial exposure in the exclusion list, you have not yet seen the number that actually ends retirements. Medicare does cover skilled nursing facility care for up to 100 days under one specific set of conditions. And when those conditions expire, coverage stops completely. On day 101, the full cost is yours. To receive any Medicare coverage, you must first have a qualifying inpatient hospital stay of at least 3 consecutive days. Not 3 days in the hospital, 3 days admitted as an inpatient. If you spend time under observation status, which is outpatient billing, those days do not count toward the threshold. The distinction between admitted and observation is a billing classification most patients never see. Days 1 through 20 of skilled nursing are covered in full. Days 21 through 100 carry a copay of $209.50 per day in 2024. After day 100, Medicare pays nothing. And here is the word that determines whether any of this applies: skilled. Medicare covers skilled nursing care, licensed clinical services, wound care, intravenous medication, physical therapy ordered by a physician. It does not cover custodial care, help with bathing, dressing, eating, moving from a bed to a chair. When your doctor determines that skilled care is no longer medically necessary, Medicare coverage ends. The custodial care you still need is not covered. According to KFF's research on long-term services and supports, Medicaid now pays for more than half of all nursing facility spending in the United States because Medicare has already run out. The average cost of a semi-private nursing home room exceeds $90,000 per year. If you want to understand what happens to your assets when Medicaid becomes the only option, subscribe. The next video covers that mechanism in full. Most people, when they discover the long-term care gap, ask the same question: doesn't my Medigap plan cover this? The answer is no, and the reason is in the same federal law.
Most people who want more coverage than original Medicare buy a Medigap policy, a Medicare supplement plan sold by private insurers to fill the gaps. Medigap pays hospital copays. It pays Part B coinsurance. Depending on the plan letter, it may cover foreign travel emergencies. What it does not cover is fixed by federal law. CMS publishes standardized Medigap plan designs, Plan A through Plan N, and no standardized plan covers dental care, vision care, hearing aids, or long-term custodial care. Not Plan F, not Plan G. None of them. The statute that excludes these services from Medicare does not authorize Medigap to cover them as supplement benefits. The exclusions follow you into the supplement. What Medigap does well is predictable. It eliminates most cost sharing for the things Medicare does cover: a serious illness, a long hospital stay. A solid Medigap plan means you pay little beyond the premium. That is real protection against acute illness risk. But it is exactly the wrong kind of protection for what the exclusion list contains. The financial exposure from dental, vision, and hearing over a long retirement is real, but manageable. The exposure from long-term custodial care is not manageable. It is potentially unlimited, and Medigap does not touch it. So when people learn that Medigap doesn't help, the next question is always the same: what about Medicare Advantage? And that answer requires reading the fine print, because the advertised benefit and the delivered benefit are not the same number. In 2025, 97% of individual Medicare Advantage plans offer some dental, vision, or hearing benefit. That number comes from KFF's annual Medicare Advantage analysis. It sounds like a solution. It is not a solution in the way most people understand it. Medicare Advantage is a private insurance alternative to original Medicare. You get all of Part A and Part B through the private plan, plus supplemental benefits. Dental coverage in these plans typically comes with an annual dollar cap of $1,000 to $2,000. That covers cleanings and x-rays, possibly a filling. A single crown exceeds the cap in most markets. Hearing aid benefits typically arrive as an allowance, $500 to $2,500, covering part of the cost of entry-level devices. Prior authorization is required for many services. Your dentist of 20 years may not be in the plan's network. And here is the mechanism most people do not read before they enroll. Supplemental benefits are not locked. The plan can reduce or eliminate the dental cap, the hearing allowance, the vision benefit at the annual open enrollment period. You find out in October what your benefits will be in January. The coverage you enrolled for is not the coverage you are guaranteed to have next year. For the one gap that matters most, long-term custodial care, Medicare Advantage is as silent as original Medicare. The statute draws the same line. To understand where the money actually comes from when someone can no longer afford the nursing home, you have to look at the other program Congress created in 1965 alongside Medicare. Medicaid is the program that actually pays for long-term care in America. According to KFF's research on long-term services and supports, Medicaid finances more than half of all nursing facility spending in the United States. It is the backstop that Medicare is not. But the way you reach it is a liquidation. To qualify for Medicaid long-term care coverage, your countable assets must fall below a threshold, $2,000 in most states. Your retirement accounts count. Your investment accounts count.
The process of reaching that threshold is called spend down. You pay your nursing home bill out of your own assets until they are gone, then Medicaid steps in. And here is what trips families every time: the 5-year look-back. Under Section 1917 of the Social Security Act, Medicaid reviews every asset transfer you made in the 5 years before your application. If you transferred money to your children, gifted assets, or placed your house in a trust that did not meet Medicaid's qualification rules, those transfers are counted. Medicaid imposes a penalty period, calculated by dividing the transferred amount by the average monthly nursing home cost in your state. You are expected to pay your own care during that window from assets you no longer have. Done at least 5 years before you need care, certain trust structures can protect assets. Done the year before someone enters a nursing home, it is too late. And here is what no one tells you at 65. The tools that actually protect you from all of this are available right now. They are in the tax code, and the window closes when you enroll in Medicare. The tools that fill the Medicare exclusion gaps exist. They are in the tax code. They have deadlines, and the most powerful one closes the moment you enroll in Medicare. The Health Savings Account. Available to anyone on a qualifying high-deductible health plan, an HSA lets you contribute $4,150 as an individual in 2024, $8,300 for a family, with a $1,000 catch-up if you are 55 or older. Every dollar goes in pre-tax. It grows tax-free. Withdrawals for qualifying medical expenses, dental, vision, hearing aids, prescription eyeglasses, are tax-free. After 65, you can withdraw for any reason and pay only ordinary income tax. Triple tax advantaged. No other account in the tax code works this way. Here is the mechanism that matters. You cannot contribute to an HSA after you enroll in Medicare. Not a dollar. The window closes at enrollment. Part A, Part B, either one. If you delay Medicare past 65 while on a qualifying plan, you can keep contributing. The moment you enroll, you cannot. For long-term care, the tool is insurance, and the price is driven by age at purchase. A long-term care policy purchased at 55 costs roughly half what the same coverage costs at 65. Premiums are lower, health underwriting is more favorable, and the compounding of your premium payments over time is greater. The economics reward early action. These are the tools. The law tells you exactly what it will not cover. Your job is to know that before you need it. The woman who turned 65 at the start of this video, the one who enrolled in Medicare and went to 3 appointments and got 3 bills, is not unusual. She is the rule. Medicare covers acute illness. It covers hospitalization and surgery and physician care for diagnosed conditions. It does not cover the maintenance of your teeth, your eyes, or your ears. It does not cover the custodial care you may need when you can no longer live independently. These are not gaps that politics failed to close. They are the design, written into Section 1862 of the Social Security Act in 1965, and renewed by every Congress since. Benjamin Franklin spent his life explaining systems to people who had been told the systems were too complicated to understand. He understood that the difference between security and ruin was usually not intelligence. It was information. And whether you had it before the moment it was needed. The Medicare exclusion list is not complicated. It is specific. It names what it will not pay for. The problem is not the law. The problem is that most people learn what the law says when they are already holding the invoice. The next video covers the Medicaid 5-year look-back rule in full, the exact mechanism, the penalty calculation, and the specific trust structures that protect assets when the planning starts early enough. Subscribe, because that is the one you need to understand before you ever need Medicaid.